Of course, I have been doing this for almost 3 decades, and at least for the last 20 years, I've been hearing that there is no role for stem cell transplant, or is it still relevant? Again, it's a very valid question, but if you look at the data, and study after study has shown that doing high-dose chemotherapy and autologous stem cell transplant, even with all the effective novel agents, improves the response rate, improves the depth of response, either by stringent complete remission or now with minimal residual disease testing, either by next generation flow cytometry or next generation sequencing. So there is still a role for high-dose melphalan or high-dose chemotherapy and autologous stem cell transplant, because all the recent trials, even with novel agents, are showing that we improve the depth of response, and almost all of them are associated with longer progression-free survival, especially when high-dose chemotherapy and autologous transplant is used upfront. Unfortunately, most of the patients are not referred for a stem cell transplant. And if you look at the data, most of the patients are not getting autologous stem cell transplant. But when it is studied in transplant-eligible patients, upfront high-dose therapy and autologous stem cell transplant is associated with deeper response, more durable remission, and a longer progression-free survival. So at this stage, I think at all major medical centers, and I think with a few exceptions, there is a consensus in myeloma specialists that autologous stem cell transplant is still an integral part of management of multiple myeloma and treatment of multiple myeloma. One important question, of course, is should this be done upfront or can it be delayed to a later time point? Because overall survival is not different between upfront versus delayed stem cell transplant. But again, it depends on the patients that we are treating. For young and healthy patients with good organ function, I think with the longest remission that one gets with upfront autologous stem cell transplant and the deep response, it is perhaps recommended to use it in the upfront setting. Also in high-risk patients where the goal is to achieve the deepest possible response and maintain it, I think upfront high-dose therapy and autologous stem cell transplant should be performed as early after induction as possible. In some patients who are reluctant to undergo an autologous stem cell transplant, one should harvest the stem cells and freeze them and offer them delayed transplant, because that is still useful. And in those studies that compared upfront versus delayed autologous stem cell transplant, almost 80% of patients actually ended up getting the delayed transplant. And as a result, their overall survival was not any different from those who got upfront transplant. So at this point, the way things stand, its role has evolved in the sense that, yes, it is a very important part of the treatment of multiple myeloma, part of armamentarium. How will it evolve in the coming years? We have to see. But we also have to see the data. We have to first do those clinical trials and show that some of the emerging treatments like immunotherapies or cellular therapies are associated with better outcomes before we can say that this treatment is not needed. So yes, it still has significant role, but it is evolving, and we have to see, and we have to do those clinical trials and ask those right questions before we can say that there is no role for high-dose therapy in the management of myeloma.